Right, I think we can get going. We've got lots of people joining, but I think most people have logged in. Good evening to everybody. My name is John Patricius, and I'm here representing WITS Sport and Health, who are bringing you another one of our webinars. In fact, one of our worldwide WiSH webinars, and it really is a worldwide one with two speakers from different ends of the world, who we'll welcome in a minute. Again, just to remind you that WiSH is an initiative of the Health Sciences faculty of WITS University, and not only during this lockdown period, but hopefully for a long time to come, we're going to present these webinars, talks, seminars, and short courses as part of our academic program to try and promote various aspects of sport and exercise medicine. And we're able to do this because we have a team behind us who supports us, and also because we have a sponsor in the Lita and Asino company, who've generously sponsored a grant towards these webinars, so we're able to facilitate all the technical aspects. Also, a big thanks to Dr. Robin Saggers, who's with us and managing all the technical stuff in the background, and to our social media team who sends out all the communications which you receive. So we're going to go on to introducing our topic and speakers this evening, and we've sort of labeled it brain games, but I think it's not a light-hearted topic this evening. It's a topic that's been quite emotive, not only in sport and exercise circles, but certainly around the world in general media and social media. And that is talking about the long-term sequelae or potential long-term sequelae of traumatic head injuries to our sportsmen and women. And to introduce the topic and to talk to us on the matter, we've got two world experts today, and we're very grateful to have from Glasgow, Dr. Willie Stewart. Willie I've known for several years as we worked together for a project which we supported World Rugby in their concussion endeavors, and it was always a pleasure to have Willie's insight. And those of you that are au fait with the literature will have recognized his name on several papers, some of which you were sent, which I always regard as a voice of reason in a very emotive topic. He comes up with good science, and he explains to us where the science is lacking. And I think we're going to hear of that today. And it's we're very, very lucky to have an eminent neuropathologist such as Dr. Willie Stewart with us. And then following him, we've got a neurologist from our own neck of the woods, from Stellenbosch, Franclo Henning, who some of you will have heard in our rugby seminars, who's going to talk a little bit about motor neuron disease and the potential relationship it might have with traumatic brain injury. So we look forward to you engaging with us through the question and answer facility. Please send your questions through, and we'll make sure we get through as many of them as possible to our speakers as they end their talks. Hopefully we learn a lot more. Please be patient. Your CPD certificates will come in the coming days and weeks. And also remember that we do record the session, and it goes up onto our website in a few days' time. So we will broadcast that link soon enough. So enough from me. I'm going to hand over to Dr. Willie Stewart, joining us from Glasgow this evening. Willie, thank you very much. Great pleasure to have you, and really looking forward to hearing your presentation. You share your screen, and then I'm going to leave it to you. Thank you.
Thanks very much, John. It's a great pleasure to connect again. It's one of the great things about the modern environment we're in, that actually we've found these rapid advances in being able to communicate across long distances, and I think it's made the world a smaller place. It's awfully nice to visit all these different countries and different centres and see what's going on, but it's difficult to always get together and communicate simply on that when there's so much travel involved. So I'm delighted to be involved in this. So my job this evening is to try and give you a kind of flavour of where we are in understanding this thorny issue, as John has suggested, of chronic traumatic encephalopathy. And I want to introduce you to a new term, trend. This is chronic traumatic encephalopathy, perhaps as a minor trend. Now, I always believe that early on in these talks, you want to try and get the crowd on your side. So Let's start with a fantastic image of the most recent Rugby World Cup and, of course, the great success for South African side. But in the background, as John and I know, there are discussions about whether this fantastic sport, fantastic participation in contact sport may have some immediate risks and longer-term complications, particularly associated with concussion and head injuries in sport. And as John has alluded to, it's generated some emotive headlines, and there's some really quite difficult stories that we always keep in mind when we're working on this. And the reason that there's such a focus on this activity in the last decade or so, as you know, has generated from observations in American football, where the long-told story, everybody I think is familiar with this story now, of Bennett Umalu, who identified a pathology in the brain of Mike Webster, a former Pittsburgh Steeler American footballer, which he described as a chronic traumatic encephalopathy. And at that time, this was a pathology which was essentially only seen or largely seen in boxers. And so seeing it in an American footballer, he felt was an important advancement in understanding that it went beyond boxing circumstances and maybe seen in other places. And as you know, that story was told in Concussion, or a version of that story. I wouldn't say it was necessarily the whole story. And from that original description of Bennett Umalu's around Mike Webster, there has been concerted efforts to characterize further this pathology and to gather more experience in more case series. And this in particular headline or news reporting from the New York Times several years ago looked at the experience from the Boston University archive, where they reported 110 out of their 111 cases at that time of former NFL players had degenerative brain pathology in them. And of course that set alarm bells ringing, because this seemed to be an enormous proportion of players. 99% of players' brains had pathology in them. And of course that's not how to interpret this, because this is an acknowledged sample of brain donations rather than the entirety of NFL participants. But nevertheless, it does create anxiety. And then another aspect of this has been other reporting of aspects of disease apparently linked to CTE. And in this case, thinking about mental health disorder, and unfortunately in this case was a suicide, and long form reporting about the link between mental health disorders, suicide, and this degenerative brain disease, which seems to arise from participation in sport. So we get to a position where I think, unfortunately, there's a common perception or misperception that CTE, this chronic traumatic encephalopathy, this degenerative brain disease, is almost an inevitable consequence of participation in some sports. That actually it's the only neurodegeneration that is of significance in TBI, that other pathologies and other diseases aren't related. That mental health issues are almost an inevitable feature of CTE, and this is sure science. And that neurodegeneration and TBI are really just something to worry about within sport, or at least CTE is. But as I say, this is perhaps misperception, and hopefully in the next 15 minutes, 20 minutes or so, I'll be able to clarify where these misperceptions have been placed. So coming back to the story of Bennett and Mike Webster, there has been some debate about whether the pathology that Bennett saw and reported was CTE. To be honest, I'm not the least bit concerned about that, and I think that's a debate which is irrelevant now, because this whatever's happened from this case has happened, rightly or wrongly, but we've certainly got better understanding of the pathologies of brain injury now than we did back in 2005 when this was first published. And actually what Bennett was doing, as I say, was not presenting us with a new pathology, but it was presenting us with an old and well-recognized pathology, but in a new environment. So in American football, an understanding of the link between brain injury in sport and late degenerative problems has been around for almost a century. 1928, Harrison Martland first described the punch-drunk syndrome in former boxers. And that link between boxers and outcome really remained the only kind of acknowledged association in sport for many years. And the pathology being described in the 70s in a well-known series of Carcellis, who looked at the brains of former boxers and described pretty much many of the facets that we see now. Certainly, the subsequent examinations of Carcellis have confirmed many of the pathologies that we recognize in more recent case series. So there were abnormalities macroscopically, there were abnormalities down a microscope, and even then the abnormalities down a microscope were mixed pathologies. And with this resurgence in interest, with this recognition that pathology could be seen outside of boxers, of course, I think I was quoted at the time as saying that it would not be a surprise to find a pathology in rugby players. In fact, if the hypothesis of this being an exposure-related issue to do with traumatic brain injury were true, the surprise would be not finding it. And within a couple of years of that, a colleague of mine, Michael Farrell in Dublin, contacted me to say, I think I've got a case. And sure enough, when we reviewed the case, they had the macroscopic pathology on imaging of a cavum septum pellucidum, which is something we see typically in players with, or patients with CTE pathology. And down a microscope, it had the tau pathology, which has now become recognized as characteristic of CTE. So this was the first case in rugby. But as I say, if the hypothesis were in any way supported, we would expect to see cases in rugby. It doesn't tell us anything about incidence of disease. But even then, when Michael and I were looking at that case, we knew what pathology we might look for, but it hadn't been formally characterized, it hadn't been formally agreed in consensus. And as pathologists, we like to have these things called consensus, where we agree exactly what it is we should be looking for, and only that becomes the diagnostic criteria that we follow. So it tries, if you like, to tidy up the potential confusions with other pathologies and distinguish a pathology from the others that might be around it. And to do this, we looked at 10 cases of CTE, all of them in the later stages of disease, from the archive of Anne McKee, who you can see pictured at the front there. And buried amongst, these 10 cases were buried amongst a number of other cases with tau pathologies, which may be confused with it. So we looked at cases that were Alzheimer's disease, PSP, CBD, and so on. And the idea is we looked at these blind to what the clinical condition was or what the pathology had been reported as in the past, and tried to identify from this pack what differentiated our CTE cases. And from that, we decided that the pathognomonic lesion, the diagnostic lesion of CTE, was these patchy deposits of tau protein in neurons and astrocytes clustered around blood vessels. And that's become the consensus agreement now on a way forward for identifying the pathology, but subject to refinement as we go along, I'm sure. So what happens if you put this into practice? Here's a recent series we looked at of former soccer players and rugby players with dementia who were donated to our archive in Glasgow, and in which we did a full workup on pathology, and also then did retrospective interviews with families and reviews of clinical case notes to identify what the final integrated diagnosis might be. An important thing to notice in this is a complicated table, we're not going to go into it in detail, but the important thing to notice in this is that yes, this CTE pathology, which we're now describing as CTE neuropathologic change, because I want to distinguish pathology from clinical outcome, and you'll see why in a minute. So CTE neuropathologic change, we do see in a high proportion of these former soccer players and rugby players with dementia, about 3/4 of them. And that holds true. The numbers have gone up and up and up, as you can imagine. The donation program continues, and we're seeing more cases. And it's around about 75%. And that fits with experience from other archives as well. But there's a whole bunch of other pathologies in these patients as well. Alzheimer's type pathologies, amyloid angiopathy, other proteinopathies, vascular pathologies. And when you actually take a step back and speak to the families and review the case notes and consider what the integrated diagnosis is, in many of the cases we're looking at diagnoses which aren't always CTE. So patients may have CTE pathology and may in fact have a clinical diagnosis which fits with CTE, but they may also have CTE pathology, but have a pathology and clinical diagnosis which is much more consistent with dementia Lewy bodies or Parkinson's disease or Alzheimer's disease. And as I say, in the majority of cases, that's actually what we're seeing. So CTE is there present, about 3/4 of patients, but it's there as a comorbid pathology, i.e. not the driving pathology, not the primary pathology causing dementia. So in summary, our understanding of the pathology side of this is that it is more one of TBI-related neurodegeneration. I haven't got into the complex mixture pathologies yet. I'll touch on that later. But we're thinking more that this is a complex, heterogeneous mixture of pathologies rather than a single proteinopathy, rather than a single tau pathology, a single pathology of CTE neuropathologic change. And this is where we come up with this terminology, TBI-related neurodegeneration, as a more inclusive, all-encompassing problem, so trend. Neuropathologic change, as I say, is present in about 75% of athletes when we look for it, in those dying with dementia. But in the majority, we're seeing it when we do a clinical pathological correlation as a comorbidity rather than a primary pathology. And importantly, CTE neuropathologic change, although we talk about it in athletes and sports and repetitive mild traumatic brain injury impact, it's actually not unique to repetitive mild TBI. We also see it in patients who've been exposed to just a single moderate or severe TBI. So it seems to be a pathology associated with brain injury, whether on a sports field or not. But importantly, I'm just talking at the moment about a pathology. We don't know the clinical significance. So pathology is one thing, its clinical significance, its clinical implications are another altogether. So how do we get at this clinical association? Well, one way is to sit down with a high-risk population, in this case, retired Scottish internationalists, and to put them through a series of brain tests to see how their brain's functioning and see whether we can detect any deficits in comparison to people who are pretty much like our rugby players but never played rugby. So men in the community who come from a similar area, similar backgrounds, but didn't play rugby. And we did that. And the short story here is when you do it, you find minimal, just tiny deficits in memory and in fine motor control and dominant hand, which are subclinical. So in other words, these rugby players would never know this problem was there, would never complain of this problem. So we find virtually nothing in terms of cognitive issues, but what we do find, and this is important, is that cardiovascular disease is present considerably lower in our controls in our rugby players than in controls. So we're seeing considerably less cardiac disease than in our controls, and not really any difference in cognitive functioning. Disappointingly, this wasn't given much of a headline. I think the reporters were slightly underwhelmed that we only found mild memory effects. So I didn't get the kind of the fanfare that some papers get when we find big deficits or big abnormalities. But maybe speaking to former players isn't the best way to do it, because when you speak to players and bring players in, by definition, they're not going to have major problems with their cognition because they're consenting for research, they're participating in research and studies, and they tend to be healthy volunteers that want to put themselves forward for these studies. So maybe there's other ways to do it. And one way to do it is to look at death statistics. Go back to Mike Webster. Following the revelation about Mike Webster and his pathology, some years later, there was a study looking at the mortality data sets for former NFL participants and suggesting that, yes, there was a higher neurodegenerative disease mortality. So that gave us an idea, perhaps, right about the same time as Mike Webster was passing away in 2002, Jeff Astle, famous footballer from West Bromwich Albion, also passed away. And that made us think, well, maybe there's something we could tease apart from death statistics in sport near home, in soccer. And at this time, the Football Association asked if groups would come forward with ideas for studies to try and address this question of whether there was a link between playing soccer and neurodegenerative disease. And so we put together a program which is football's influence on lifelong health and dementia risk field. Easier to say field than it is remember the acronym. And the principal aim of that was to try and identify whether there was any difference in neurodegenerative disease incidence in our soccer players than matched population controls. And to do that, we're very fortunate that there was a gentleman who collated pretty much everything you want to know about Scottish soccer players going back to the 1900s, early 1900s, right through to the modern day, which allowed us to identify every Scottish footballer who'd played in the professional leagues. When we took that data set that he provided, many players had multiple entries. So John Patricius could play for Glasgow Celtic and then cross over and play for Glasgow Rangers, and there'd be 2 lines of data for him. So our PhD was set the task of whittling down almost 70,000 lines of data to single patient or player entries. And from that, we managed to identify just under 8,000 of these against their community health index number. Now that gives us a direct link to their electronic health records. So just under 8,000 former professional soccer players matched to their health records. And from that, we could then identify people within our community who were matched to them by age, by year of birth, gender, these were all males, and by an index of social deprivation, which looks down to the postcode level at factors to do with housing, employment, education, crime, access to healthcare, and so on. So we can get an index of social deprivation. So we matched our around 8,000 footballers to 23,000 population controls. The first thing we found was that mortality was slightly lower in our footballers. Great news. They lived on average just over a year longer than population controls, but this was an effect which was dependent on age. So the younger footballers' risk of death, hazard ratio risk of death, was lower than in our older footballers, and the pivot point was around 70. So over age 70, mortality was slightly higher. Under age 70, mortality was lower in our former soccer players than the population controlled. Digging deeper into that, we found that when we looked at specifically what was going on, ischemic heart disease, again reflecting back on our rugby study, finding less cardiovascular disease in our rugby players, ischemic heart disease as a cause of death was about 80% in our former footballers than in the controls, lung cancer about half. But here's the standout: neurodegenerative disease, all-cause neurodegenerative disease, cause of death was 4 times higher than expected from our population control data set. And that's a remarkable number. If you just look at the raw numbers, 134 of our footballers died of neurodegenerative disease on the death certificate primary cause of death. If you remember, we've got 3 population controls for every footballer, so we should see 3 times as many controls with death due to neurodegenerative disease. So we're looking at almost 400, here 120, so matched. Look at the causes of death again, 134 died of neurodegenerative disease, almost as many as died of ischemic heart disease, a common cause of death. So this figure begins to grow into stark contrast and highlight. But remember, we know that our footballers are living longer because they get less cardiovascular disease, less lung cancer, so maybe all we're seeing is an effect of age. So we adjust for that. We adjusted for the competing hazards of ischemic heart disease and lung cancer. When you adjust for that, the true underlying increase in neurodegenerative disease across the ages, and we were examining footballers from age 40 right through to over 90. So the risk of neurodegenerative disease across that age span is just under 3.5. Looking deeper into this, looking at specific causes of death, so specific neurodegenerative diseases. So here we're looking at not just the direct cause of death, but also contributing factors. So in the death certificate, you've got the immediate cause of death and other causes that are of ill health, which influence death but weren't directly contributing to death. And when we do that, we can look in a bit deeper at subtypes of neurodegenerative disease. And the short story here is that the risk varies. So Alzheimer's disease, common cause of death, common cause of dementia, 5-fold increase than expected in our footballers over our population controls. Parkinson's disease, just over a doubling. Motor neuron disease, we're going to hear a bit more about that in the next talk. Motor neuron disease, 4-fold increase. Again, look at the numbers, 22 footballers with motor neuron disease, 17 population controls. By the numbers, there should be almost over 80. Now, putting this together with what we know from the neurodegenerative disease, from the NFL data, putting our studies side by side. Now, there are differences in methodology, so they're not directly comparable, but it's interesting just to put them together and get a sense of what we're seeing here. And the story we're seeing here is that actually there's surprising similarities in the numbers, even allowing for the differences in approach. This looked at population data, general population data, without case matching. This looked at matched population data. It's a hazard versus a standardized mortality ratio. But look, the numbers are very similar, including motor neuron disease risk being higher. What we didn't publish in the paper, but we did have data in the background, and we're working more on this, was to what extent this might be an exposure-related issue. So one way to do that is to look at career length. So the longer you play, if this is a risk to do with the sport, the longer you play, you might expect the risk to go higher. And the short story here, these data aren't great. Where we've got much more robust data coming through that shows much the same, is the longer you play football, particularly longest career lengths, the higher risk of developing neurodegenerative disease. Quickly, just touch on mental health. This reporting that CTE and mental health are somehow inextricably linked. I find it really difficult to figure out where that story is coming from, because when you actually look at studies certainly from pathology side, there doesn't seem to be any great evidence to suggest that. Certainly suicide, there's no greater risk. Yes, there's a risk of dementia. Yes, some aspects of neuropsychiatric disease do show a fairly weak association, but there's nothing really to say there's a strong association with mental health disorder, in particular with suicide. So where this story has come from, I'm just not too sure, and sufficiently concerned were I and over 60 of my colleagues around the world in this, that we actually wrote Lancet Neurology asking people just take a step back and just hold back on reporting on this risk until we get more information. Well, we have that now. Remember our footballers, going back to the same population, where we know they've got a 3.5-fold increased risk of neurodegenerative disease. So you would think, if the story about sport and neurodegenerative disease and CTE and everything else is held true, then we should see more mental health disorder. In fact, what we find is that contrary to that hypothesis, actually, we're seeing mental health disorder rates for the common mental health disorders, including depression, alcohol use, things where we're really concerned in a wider population sense. We're actually seeing it at half or less in our former professional soccer players, despite the high levels of neurodegeneration, and we see no difference in suicide. Actually, the suicide numbers are slightly lower, but the numbers in total were so low that the statistics were hard to make to say with certainty. And just to remind you, this isn't just an issue of sport. Some of you may have come across this from last week, Lancet Commission, looking at the potentially preventable causes of or modifiable causes of dementia in the community, and they have come forward this time and said that actually head injury should be included in this list, and that head injury probably contributes around 3% of dementia in the population. So dealing with head injury potentially could remove 3% of dementia in the population. My feeling is that's, as a general population sense, if we go into sporting groups, that risk is higher. The proportion involved is higher. But it's important now we're seeing this isn't just a sports problem. This isn't just a CTE problem. This is a wider society problem to do with head injury, and wider than CTE. It involves other dementias too. So this is really where we are at the moment in thinking, is that that really, getting a hit in the head, whether it be repetitive mild injuries, sports-related concussions, boxing, rugby, football, or a single moderate or severe TBI, produces a whole constellation of pathologies in the brain. Amyloid pathologies, axons degenerate, inflammation we haven't even talked about, atrophy, septal abnormalities, the classic tau of CTE. So all these things happen. And these pathologies in themselves are of questionable, unique, and individual significance. So what I mean by that is, just having the tau doesn't mean you develop CTE. Just having the amyloid doesn't mean you've developed Alzheimer's disease. It's how these pathologies interact and intermingle, and ultimately how they present clinically, that defines the syndrome. So if this is a tau-driven pathology, then CTE is reasonable. If it's a mixture of tau and amyloid and other pathologies, it could be Alzheimer's disease, and so on. And we've only considered 3 of these, but there are many more. And this is the program we've just begun under Connect TBI, which is another acronym, which is easier to say than it is to explain. And if you click on that link, you'll find much more information on how we're going to try and unpick all of this. So to summarize, CTE, a minor trend. TBI-related neurodegeneration is really what we need to be thinking about now, not about CTE specifically, not about sport specifically, but let's think about TBI-related neurodegeneration. It's a much more wider societal and much more complex problem. It's not unique to sport. It is a mixture of pathologies, even in athletes. CTE neuropathologic change is common, as I've said, but possibly a comorbidity and maybe then a minor pathology, minor trend. Mortality from neurodegenerative disease, however, is high in professional soccer players and in the NFL, and I suspect if we can get similar data sets, we may find similar data emerging. It's not just CTE though. You know, the CTE is perhaps just one minor dementia subtype, again, minor trend amongst the others that are associated here. The clinical phenotype varies. Player position, player career, and there are other variables here we're looking at which are subject to another talk entirely. Psychiatric disease and suicide, no evidence in professional soccer that there's any increase. In fact, it's lower. No evidence that there's any increase in suicide. So I just wonder whether, you know, the story in wider athletes is the same as well. If we actually, you know, unpick what's happening in American football, unpick what's happening in hockey, unpick what's happening in other sports, we may find it in retired athletes. There's probably a very similar story to soccer, but it's being lost in the fog of reporting, perhaps, of headlines rather than data. But let's keep in mind, sport is good. Lower ischemic heart disease, lower cancers. I'm not saying it's good for the knees. That's coming up in another talk. But sport in general is good. We do not want to lose the benefits of sport, the benefits of seeing South African rugby lift the World Cup and the boost that gives us all and participation gives us all, for the sake of you know, the concerns about head injury, because we can do something about this. We can reduce the risk of TBI and head impacts. We can manage them better, and perhaps then we have this wonderful win-win where we have low levels of neurodegenerative disease or lower levels of neurodegenerative disease and all the health benefits of sport. So that'd be a win-win. So I'll just finish with thanking the people who've supported us in funding in this, and also mentioning the people through Glasgow and University of Pennsylvania who've primarily been involved in this research. Thank you.
Willie, that was fantastic. Thank you very much for the presentation. One of the things we do before each of these presentations, we set up a little WhatsApp group in the background so we can just manage things and see how the speaker's doing and whether the volume needs adjusting, etc. And the first thing I got was a message after about 7 minutes of your talk from Robin saying, wow, this is slick. And that's a great way of describing it. I don't think people realize how much information you got into that 30 minutes and how easy it was for us to comprehend it. So thank you very much for taking a very complex topic and making it so easy to follow. Thanks. And actually giving us a lot of food for thought and an understanding of a few things. The first thing is that sport is overwhelmingly positive, and I think that's a good message for all of us to keep conveying. What is interesting is that sort of contrast between the benefits to mental health generally on one side, and then that contrast with the stark rise in neurodegenerative statistics. How do you explain that? Is it possible to explain it? Is it just a disconnect between pathology and clinical presentation, or do we not really understand it yet?
No, I mean, I think in a sense, some of the literature in the last couple of decades has probably leapt ahead of itself. So the link between neurodegeneration and mental health outcomes is a bit premature. You know, as I say, I don't think there are data there to support that link. And where your clinical data set is based on retrospective interviews of family, you may get a slightly more biased appreciation of what's going on. I think that's what's happened. So I think we need to kind of just take a step back, you know, and look at the wider picture. We know, I mean, one of the things that really strikes me is cardiovascular disease we know is a risk factor for neurodegenerative disease. We know that mental health disorders can be a risk factor for neurodegenerative disease. So we're seeing lower levels of that in our former soccer players, lower cardiovascular disease, lower mental health. so we would almost expect, we almost hope that the neurodegenerative disease picture would be better than it is, you know. So I think again, it just flips into contrast this real concern we have with the levels of neurodegenerative disease, that actually this is something really significant and needs to be dealt with. So I think dementia, cognitive impairment, neurodegenerative disease defined in classical terms clinically, I think there's good strong evidence for all that now, and that's what the pathology is looking like. I think mental health disorder, there's not so strong evidence, certainly not clinically, and I think, you know, the pathology on that is difficult to interpret.
How much data do we have from sports like boxing, where there's actually deliberate attempts to cause brain injury? I mean, are there data which contrast boxing with other contact and collision sports?
It's surprising, you know, for boxing, we haven't been at this for a century. There's surprisingly little data to work with on this. I mean, part of that is there are fewer boxers. Part of that may be that you know, we've kind of assumed boxers are going to inflict brain damage on each other. So why is that a pursuit of interest? But it's one of these things that we would dearly like to get a hold of. We're very fortunate that we have access to really good, secure health records, electronic health records in Scotland dating back to 1980s. So if we can identify a good population, you know, identified, you know, comprehensive population of athletes, boxers, I'd like to get track athletes, tennis players, you know, we'd like to get people who are from different circumstances and put them into, you know, our model now we've got it, and see what we can see the outcomes might be. We also know the effect size where we didn't before. So we didn't really know what we were dealing with in footballers. How many footballers did we need to study to try and understand this? We now know that. We now know the risk is 3.5 times higher, which makes it easier to go into, you know, different environments like rugby or football, or boxing or track athletes, and begin to figure out what kind of population you might need to work with.
Great. A question here from Faye Sinnott, who's asking about the functional and occupational capabilities of these cohorts that you studied. Was there an effect on their ability to carry on their work, their family lives, etc.?
So in the face-to-face rugby player ones, not at all. I mean, I would say the very limited functional deficit we found was one that we found, not one that they told us about. So we sat with a pegboard, timed them, and found they were slightly slow. They didn't say, by the way, you know, the most they might complain of is down the golf club, you know, trying to get, you know, grab some nuts from the bowl was a bit more of a challenge for them. So there was nothing there. In terms of our cohort looking at the former soccer players, the important thing about this is we didn't do any face-to-face on these people. This is the security of the health records examinations we do is that we identify our soccer players, we hand them over to the research division that looks after health records access. They match them to their health records, they match them to population controls, then they anonymize the whole thing and send it back to us. So we know who's a footballer, but we don't know who that footballer is. So we don't have a chance to directly go back to them and ask these specific questions, but we do have, as you're probably not surprised to hear, a variety of follow-on studies planned. Now, again, we've got a better idea what we're aiming for, to look at the footballers face-to-face and begin to ask these questions. So that's a really good observation.
Super. David Milner, who's one of our experienced physiotherapists in soccer, I'm going to make sure he doesn't receive his CPD certificate because he's asking a question which was answered in one of your papers, and that is there a difference between the goalkeepers and the outfield players? And I think you described that well in one of your papers.
So I mean, it's a really important point because, again, because we can't go back and speak to the players directly because it's part of this, you know, the way we're doing this big data studies, we need to look for surrogates. So we look at career length. That's an exposure metric. If we're thinking it's to do with head injury, then we look at player position because goalkeepers inherently are lower risk of brain injury and head impacts just from heading, you know, in football than outfield players. And when we looked at that, the rates of neurodegenerative disease by death certification weren't statistically significant between goalkeepers and outfield players. Now they were lower in goalkeepers, but not statistically lower. And we've got to be careful we don't, you know, mix up our numbers here. But what we did find, though, in another corroborative way of looking at neurodegenerative disease, we looked at dementia prescribing. And prescribing for dementia in our goalkeepers is about half that we saw in outfield players. So there is a difference there in goalkeepers. And I will tell you that just between us and the 300 people that are on the line, but keep it between us and 300 people on the line, we've got more data coming up looking at player position. And actually we can look at goalkeepers in a much more granular fashion and compare to outfield players, and even look across the lines of outfield players. We can't look at specific positions yet because the numbers aren't great enough, but we can compare defence to forward to midfield and, as I say, to goalkeeper. And all I would say, the summary of that is, if I were playing soccer, well, I did play soccer, I was terrible at it. I was so bad at it, actually, I played in goal. So well, I may have saved myself in soccer being so bad playing in goal, but I lost it all playing rugby in front row. So, you know, it's all balanced.
Excellent. What about genetic factors? We've got a question from Chanel Defenter. Genetics, have those been studied enough? Is there an influence of that on this whole?
Haven't got the data. There have been a couple of small studies looking at ApoE as a kind of low-hanging fruit, but the numbers are so low. I mean, we're talking 30, 40 American footballers or boxers, and you know, you can make an inference in all ways depending on these small studies. So, but that's something that I know people are working on hard.
Okay. Last question before we let you pour your single malt and sit back and listen to the next talk. Any evidence regarding the effects of concussion in the younger years, school playing years? Does that have an impact on neurodegenerative disease later on?
So the data from our good colleagues in Boston would look at career length and some data on when the players started participating, and suggest that the kind of younger you start, the greater the risk. I'm not sure we've got enough of that data elsewhere to be able to make those comparisons, but it's certainly something that we'd be concerned about. And I think, to be honest, I mean, if you're going to suggest that we modify the game, so modify risk of concussion and brain injury in rugby because we're concerned about, you know, the elite athletes we're dealing with, I think you've got to take a really even more sensitive approach with you know, juniors and amateurs, as you know, as you and I did when we were dealing with the concussion protocols around rugby, and just assume there's a problem there and work with that. I'm working on something to do with adolescent soccer and injury risk, which will come out soon. But we're also looking at sex differences. That's very, very important. I would say that you've got to be really cautious with the female athletes on this. More cautious, much more cautious than the male.
Super. Again, thank you very much, Willie. It was a superb presentation, more than we could have wanted. You're welcome to stay on for the rest of the seminar. Sit back and enjoy. There may be a few other questions at the end.
Sure.
In the meantime, I'm going to ask Franclo Henning to share his screen with us as I give a brief introduction. Franclo is a neurologist. He's a PhD, and he is in practice in Stellenbosch and attached to the University of Stellenbosch. He's been a great resource and an asset for South African rugby in our educational efforts in this area. And just like Dr. Stewart, he's really got a wonderful way of summarizing very complex issues and putting them to us so that we can understand. So, Franclo, we look very forward to your talk on motor neuron disease and its potential relationship with contact and collision sports. And obviously, this came to the fore predominantly with a few of our rugby players, the most prominent of whom was Joost van der Westhuizen, and his battle with this disease. So we look like we're all set up. Franclo, over to you.
Hi, good evening. Thank you, John, for the invitation. What I'd like to tell you tonight is definitely a little bit more philosophical than what we just heard from Willie, but much less data to show you, but a bit more philosophy. But still, I think it's an interesting topic to talk through. So I was asked to say something about MND or ALS and collision sports. So just briefly, I realized that it's a whole diverse bunch of participants tonight. So maybe just a little bit of background of what is meant by MND ALS. So that's motor neuron disease, or probably better term diseases. Some of the synonyms is amyotrophic lateral sclerosis or ALS, and in the States it's also used as Lou Gehrig's disease. So this is really not a single disorder, but it's a group of disorders that affect the motor neurons of the nervous system. It's degenerative, so it's also called, it's part of the spectrum of neurodegenerative disorders. It's progressive and incurable. So the commonest form of motor neuron disease is amyotrophic lateral sclerosis, about 90% of cases, and that refers to both upper and lower motor neuron involvement. You get pure lower motor neuron forms called PMA and pure upper motor neuron called PLS, but the most common form is ALS, and therefore the terms MND and ALS is really used interchangeably. Now, the peak age of onset is in the 60 to 79 age group, probably more 60 to 69, and it seems to be a bit more common in men than women, with a median survival of between 2 and 5 years. But again, that median survival is related to a group of people. As you can see from this 30-odd patients in the publication, survival varied between 12 months and 84 months, so 7 years from diagnosis. So really a very wide variability, and more reason why we believe that it's not a single disease. You get a young onset form of ALS, that's defined as onset before the age of 45. This is about 10 to 20% of cases, and the male to female ratio is a little bit higher in this group. Now, in South Africa, this disease has been made famous by firstly US Universitation, as John was referring to, but also people like Tinus Lanier. So the disorder affects limb muscles, so arms, legs. It often starts in a single hand or a foot, swallowing, speech, breathing. So it really does lead to a very debilitating disease and leading to people being very much locked into their own bodies in a way. So the incidence varies between 1.5 and 2 per 100,000 per year. This is mostly in the Western countries. And of these, about 5% are familial. In other words, it's another family member with ALS. But we know that mutations causing this disorder is present in another between 5 and 25% of sporadic cases. However, the other 70 to 90% of people with this disorder are called sporadic ALS because there's not a clear genetic cause shown. So with that background, what about ALS in sport? Now, this has been in the news for many years. In 1962, a neurologist said nothing has been said about the possible role of or in etiology of a previous habit of athleticism. I have the uncomfortable feeling that a past history of unnecessary muscular movement, which I find very funny, carried out for no obvious reason, may be followed in later life by the development of motor neuron disease. So for many years, this has been a topic of discussion. So what I would like to touch on tonight, firstly, is physical activity a risk factor for ALS? And if so, is it in general or just in certain sports? Secondly, is head injury a risk factor for ALS? And thirdly, what is the role of genes, if any? Now, firstly, physical activity. There's been a whole lot of studies, about more than 40 at this stage, of physical activity in ALS. Two literature reviews, and this includes 2 literature reviews, a multi-center European collaborative case control study and multi-center European collaborative prospective study. And they've all come to the conclusion that physical activity is not a risk factor for ALS. But there is some evidence, level C evidence, so possible, that professional soccer and American football may be risk factors for ALS. So Willie has alluded to some of these already. Firstly, just the ALS and soccer. First study that got this going was really in late 1990s, when there was a complaint by an Italian coach about the fusion of illegal drugs in football players, and then an Italian prosecutor who was particularly interested in litigation with regards to drugs and so forth. He ordered an inquiry, and they looked at a few thousand cases of a few thousand soccer players in the Italian professional and semi-professional divisions, and then what they noticed was that out of 375 deaths, 8 were due to ALS. And he then approached the authors of this study. And what they found then is that among more than 7,000 Italian soccer players who played between 1970 and 2002, 5 had developed ALS. And that they calculated the standardized mobility ratio. In other words, the diagnosis of ALS compared to the general population, it was 6.5 times higher in these players. The other study about soccer, Willie has already referred to, but I'm just going to highlight motor neuron disease itself. About more than 4 times hazard ratio in former soccer players compared to match controls. And then the NFL study that he also referred to, NFL players in the USA, about 3,500 players, and they examined death from neurodegenerative diseases and amongst other things ALS, and they found 7 ALS cases, which came to a standardized mortality ratios of deaths versus the standard population of 4.3, which is significantly higher. But now, I've already showed you that there doesn't seem to be any evidence that physical activity is a risk factor for ALS. But it does seem like these 2 sports might carry some risk. But we're not quite sure why that is. And we're also not sure that it's limited to these sports. Remember, it's very difficult to get a large enough cohorts together of people who play individual sports. Boxing would be one of those examples. So it's quite difficult to investigate this. But then what about head trauma, which is really the brunt of the talk tonight? Now, collision sports are defined as a sport in which athletes purposely hit or collide with each other or inanimate objects like a soccer ball. So one's got to try and untangle multiple episodes of minor head trauma from distinct episodes. There's research on both of these, but they tend to break these into 2 different types of injuries. So again, back to the NFL study. What they did as part of the protocol was to look at what they called non-speed and speed players, with the hypothesis that these speed players would be at higher risk of high impact collisions. So I don't really know the game very well, so I had to go and check what speed and non-speed players are. So as you can see on this slide, the non-speed players are the line players, would be these in this picture, and the speed players would be those, the offense and the defense wide fielders. So all the others would be the speed players. So so the different types of head injury that you see in them, keep it on the left video first. So you can see it's relatively low impact compared to the rest, but look at this now. On the right video, you can see this player is actually using his head as a weapon. So that's the reason why the speed players were then separate from non-speed players to look at risk. And in fact, most of the risk for ALS seem to come from the speed positions, 6.24 standardized mortality ratio. Now, of course, this does not imply causation. There may be a correlation, but it does not necessarily mean that there's a causative relationship. Now, there are some neuropathologists that have proposed that CTE and ALS is on the same spectrum, and ALS can be a variant of CTE. And again, Willie has referred to Anne McKee, really started there in Boston, this theory. They examined 12 cases of CTE and found 3 cases of ALS in those. But this really received quite a lot of criticism from from clinicians who really raised the point that this is more likely to be 2 different disorders that occurs together coincidentally. But then another publication from the same center where they looked at 85 brains from former athletes and military veterans or civilians, all with a history of repetitive mild traumatic brain injury. 51 of those had neuropathological features of CTE, and 8 of those also had clinical and pathological features of ALS. Now, one's got to remember there would be some problems interpreting this study as the authors wanted us to do, in that ALS is a form of CTE. There's a substantial sampling bias. So all their referrals all these postmortems were based on referrals. And they were likely, they don't really give details in the publication, but they were likely referred because either the families or the physicians suspected an association between the person's symptomatology, whatever that was, and his NFL years. And it's, as Willie also alluded to, we don't know how many players without any symptoms actually have features of CTE, or mild, at least some features of CTE on post-mortem. So it's, and the other issue here, of course, is that all the clinical information was provided by family members post-mortem. And it's very difficult to distinguish between CTE clinical features and that of FTD, frontotemporal dementia. And this is present in 15 to 20% of people with ALS. All of this, they could have impaired concentration, behavior abnormalities, etc. So there's a lot of overlap in the clinical features. And these were all collected post-mortem. Furthermore, 2 of the cases had a family history of neurological disease. One had a brother with motor neuron disease. One had a father with undiagnosed dementia. So again, the question is raised whether this is not just 2 separate disorders. And it's very difficult to make any epidemiological conclusions from such a study. Furthermore, such a theory that really just doesn't sit well with clinicians who see patients with ALS. For example, in the USA, there's about 5,000 new cases of ALS every year. And to suggest that head trauma is the cause of the disorder in such a small group of people with otherwise typical ALS just doesn't seem to hold up. But I accept that as anecdotal. Then what about distinct episodes of major head trauma? Again, there's been numerous studies looking at this. The major problem, of course, is recall bias. People with a diagnosis are more prone to report past events that they relate to the diagnosis, and normal individuals tend to underreport past exposure. And if you take those 2 together, the odds ratio increases. So all retrospective studies are hampered by this issue of recall bias. There were, as you can see, there's about at least 3. I only highlighted 3 of the larger ones, all of them with an OR of in the range of 2 to 3, a odds ratio of 2 to 3 up to 4 even, related to head injuries. But so recall bias can really only be overcome by 2 things. Firstly, if there's blinding, so neither the subject or the observer knows that he's a case or control. Or secondly, if you can use data that were recorded for other purposes before the outcome had occurred, and therefore before the study had started. Now that is quite unusual, but there is one of these. It's the Oxford Record Linkage study. It was performed in the southeast of England. And this study contains records of all hospital admissions, including day cases for trauma, whether it was head injury or limb injury. And so these investigators could follow these, could retrospectively look at the records of admission for injuries and look at death records for the population over a span of 36 years. And what they found was that the risk of developing ALS was similar between the 2 groups. In other words, those who had head injuries and who didn't, except for during the first year after the head injury. But that could quite easily be explained by incipient ALS, because before the ALS takes about a year to diagnose, and that is standard figures from across the world. So these head injuries probably are related to falls due to incipient ALS. Then, of course, there's always the issue of environmental factors as a risk factor for ALS. Now, there's a whole lot of retrospective studies. Again, I think I'm only going to highlight one meta-analysis and literature review looking at, for example, sports. We've already covered that, but then also metals and chemicals. And all of them, as you can see in this picture here, has risk ratios of a little bit higher than 1, up to 2 sometimes. So really, if the risk factor at all, it's not very big. And that seems to be the case across virtually all the studies. So that includes pesticide exposure, fertilizer exposure, lead, paint, and so forth. So I hope I've shown you that there's really not a lot of evidence that head injuries or physical activity or environmental factors can really explain the increased numbers that we see of ALS in participants in soccer and American football. So the question is there an alternative explanation? Now, the bad news is that I don't have this explanation, but I have a few ideas that I'd like to expose you to. But firstly, just a few interesting points. We alluded earlier, I think, to the fact that cardiovascular risk factors increases the risk for neurodegenerative disease, which is true. But it's not true for ALS. It's true for dementia, but not for ALS. In fact, we know that people with ALS have lower use of cholesterol-lowering agents. That's even pre-morbid. They have a lower pre-morbid BMI. They've got a more favorable lipid profile. And people with a record of coronary heart disease have a higher risk, without a record of coronary heart disease, have a higher risk of developing ALS. So the more healthy you are cardiovascular-wise, the higher the risk of developing ALS. And there's 2 studies that I'd like to mention about ALS and physical fitness. So there's a study from the US that suggested that people with ALS are more likely to have been varsity athletes. But I'd like to highlight the second study, because this is really a phenomenal study. It's performed in Sweden, and they collected data on nearly 700,000 men. So in Sweden, there's still a conscription program for military service, and all men who turn 18 are subjected to a physical examination that includes strength measurement by means of dynamometry, as well as physical fitness test, which is a stationary bike test where maximum power is measured. So the authors then looked at data over about people tested over about 14 years between 1951 and 1965. This was published in 2012, so 50 to 60 years earlier, and they could follow all these men and compare those who died from ALS to those who died from a different cause. And it seems like weight-adjusted physical fitness, as they call it, which is really weight, power to weight ratio, but not strength, as a risk factor for death from ALS at an earlier age. So most of them died before the age of about 50. So, and you can see that the odds ratio, but nearly 2 for physical fitness. So this would suggest that there is probably something in the genetic predisposition, and perhaps the same genetic predisposition that, and I think it's pretty much agreed to, that a large part of athleticism and body habitus and lipid profile is genetically determined. So the question is it not possible this same genetic predisposition could also predispose one to developing ALS? So just a little bit on genotype in ALS risk. There's some data on this. So as I mentioned earlier, about 75 to 90% of cases of ALS are sporadic. However, the 10% of those that are called inherited really refers only to those that are monogenic inheritance. But ALS is more likely to be a complex inherited disease. In other words, oligogenic or polygenic, or a combination of genes in the environment. And it's becoming more and more clear that the traditional model of familial versus sporadic is probably outdated and not really relevant. It's more likely that there's a spectrum of genetic contribution ranging from those with a monogenic or a Mendelian inheritance. In other words, those the 10% that have a single gene defect that leads to the disease, and that's a single gene defect with a large effect size. But on the same spectrum are those people with oligogenic inheritance, so probably polymorphisms in more than one gene that carries a risk for developing ALS. Polygenic, in other words, quite a few, a larger number, and then the combination of oligogenic or polygenic risk factors with environment. And so these would refer to genetic changes that have a small effect size, but the sheer volume or numbers of the defects could lead to development of the disease. So something else to consider is that heritability of ALS is 50 to 60%. So heritability is a term that I'm not sure is very well known. It was quite foreign to me as well until a while back. Heritability is actually, it's a statistical concept that describes the variation in a trait that can be explained by inheritance. And it relates to not to an individual, but to the population. So in other words, a blue eye color has a heritability of, I think, 70 to 80%, whereas certain behavior traits may have a 10 to 20% heritability. So it really just describes what contribution in the population genes have in developing a trait or not. And we know now that the heritability of ALS is quite high, 50 to 65%. We also know that in patients with more than one or a variant in more than one gene that is implicated in ALS may have an earlier onset of the disorder. And this kind of studies are only now becoming possible because of the new next generation sequencing. So this is all data that has come to the fore over the past few years. And then the third, more anecdotal point is that if genetics plays a role, one would expect differences in incidences of ALS in different population groups within the same region. In other words, in heterogeneous populations. So most incidence studies come from either Asia, where there's a very homogeneous population, or European populations or North American. There's very little data from heterogeneous populations. But our own data that we collected in the Western Cape over about 4 years prospectively shows this. This is a chart showing the incidence of ALS in different regions of the world. So for example, there's Western Europe. Now, what you can see here is that our European ancestry population has got an extremely high risk or incidence. The standardized incidence is 2.62, on par with, for example, New Zealand. On the other hand, our African ancestry population group has got what seems to be the lowest risk in the world, and our mixed ancestry somewhere in between, as one could perhaps guess if one looks at the different genetic contributions. So if we look at this table again, that I showed you earlier. So we said that the speed players have a very high risk. So the question then remains, is this cause or effect? Is it not perhaps because they are so fast and so athletic that they also carry a higher risk for developing ALS? If we look at our own players that have been diagnosed with ALS, positions played, all of them were backline players. And in rugby, I would argue that you have a higher risk of recurrent high impact head injury as a forward player than a backline player. Now, there was one study, however, that they looked at ALS risk in professional, among former professional American style football players and American baseball players. And they found that the risk in the football players are still 3 times higher than the baseball players. And the conclusion they made from this is that it's perhaps rather things like body habitus and head trauma rather than things like physical activity that causes this risk. Personally, I'm not convinced that these players can really be regarded as on par with regards to physical prowess as their counterparts in National Football League. So, lastly, I think what I'd like to propose is that I would think that there's a genetic predisposition for ALS, which we know there is. And perhaps acting onto this genetic predisposition may be environmental factors, some other unidentified risk factors, or perhaps recurrent head trauma. And this may ultimately lead to multiple hits, as somebody has called it, the conspiracy of genes, environment, and time, which may ultimately lead to a person developing ALS. But as you can see from what I've said, this is very much theory and speculation. So just to recap what I said, I think it's clear to us that physical activity is per se is not a risk factor for ALS. There may be an association between ALS and certain sports, but it seems to be only at the professional level. And remember, association does not prove causation. It's very uncertain whether head injuries have any role in the development of ALS, but specifically, I'm not referring to neurodegenerative disease in general. I'm talking specifically about ALS. And I think it's plausible that a genetic profile that promotes athleticism in youth may actually be deleterious to the aging motor system. Thank you for listening to me.
Franclo, again, thank you very much for making a very complex subject very understandable for us and giving us those take-home messages, which I think really, again, hit home the point that sport overwhelmingly is beneficial. Physical activity is good for one, that we don't have all the answers for this, but that it's a complex combination of factors that probably may lead to this association. From one of our viewers, could you comment on potential association with sex, differences in sex hormones playing a role in ALS as contributory factors?
Yeah, I'm afraid there's really no data to really mention here. From most Western countries, it now seems that the more recent data suggests less of a difference in incidence between males and females. So from the European and North America, it seems to move closer to 1-to-1 than was thought before. But other than that, I have no knowledge of any evidence looking at hormonal differences to explain this whatsoever.
And in terms of the profile of the sportsmen that certainly we're aware of who have suffered from this condition, they're relatively young compared to the ages that you quoted right at the beginning of normal sort of motor neuron disease. I mean, is that a feature that if these sports people get it, they tend to be getting it at a younger age, or is it spread over a wider age group and it's just that the prominence of these brought to our attention?
So I think it is at a younger age that they do develop it. I'm going to have to look at the NFL data a bit more carefully. But if you look at ours, the 5 I showed you, for example, only one was in a kind of a typical age group. I think Danny and Don, the others were all very young. Now, one's got to remember that 10 to 20% of people do present before the age of 40 or 45. And we're looking at very small numbers here, our numbers at least. But the American football players, if I remember correctly, were also somewhat younger than the average age of onset. So it does seem to be a trend, yes. But I'm not sure what to make of it.
What about the duration of a career, exposure to physical activity, and perhaps the intensity of the activity? Could you comment on those two things, the intensity of the activity and the duration of a career in sport?
Yeah, so Willie showed us a slide where it seems that cases with people who have been exposed to or have been partaking for longer may be a relationship between the duration of exposure or playing and developing of neurodegenerative disease. So I don't think there's any data for ALS per se on that. Not that I'm aware of. What is definitely there is the fact that it is high level participation, in other words, professional or semi-professional players. In our own group, for example, here in the Western Cape, there were 5 previous or former provincial players and a single former Springbok player. But they were all diagnosed at a fairly young age, all within the 40s. That's excluding the ones I showed you on the slide. That's only from the Western Cape. But I'm not aware of any data on duration of participation. I think the data that Willie showed was some of the first that is going to be available on that topic. And Willie is welcome to correct me if he knows anything more about it than I do.
Any comments on that, Willie, at all? You're on mute, sorry.
So, suddenly, yeah, no, suddenly get lost in the buttons there. Yeah, I think we're all challenged by data. So, you know, we had a study looking at 8,000 former footballers, which sounds great. You know, it's a fantastic large study, 23,000 controls. But when you want to really get into the nitty gritty and ask these really important questions, you start to run out of numbers quite quickly. So, you know, getting down to ALS, motor neuron disease now, we had 17, which is far more than any other study, but it's still, you want to ask then about career length, about player position, about all these other fantastic questions. You just can't really do it so easily. So I think what we really need to start doing is thinking about, you know, bringing together all these cohorts and trying to address the big questions with large numbers.
Okay. Henlo, you spoke a little bit about environmental factors, and there was an issue around potential influence of fertilizers and chemicals used on the fields, etc. Can you elaborate a little bit on that at all? Is it just a myth? Is there anything to it at all?
So the data from those environmental studies, as I mentioned, there is a elevated risk for insecticides, somewhere between 1 and 2. But often in the studies, the confidence intervals cross 1. Now, so I think very few neurologists or people who work with ALS actually believe that there's a real risk related to that. If anything, it's one of those contributors that I mentioned in the end. It may be one of a number of hits that you need, but on its own, there's really no evidence to say that it's of much risk. The other issue that, or a very interesting discussion, is about what's called BMAA, which is a non-protein amino acid. This has often come to the fore in discussions, especially in lay publications, and this was for the first time seen in Guam after World War II. There was about 100 times higher incidence of ALS on the island, and this was ascribed to the psychats that people consumed, and these psychats contain this BMAA, which is actually produced worldwide. The green that you see on dams, that's cyanobacteria, and they produce BMAA. And it seems to be a non-neurotoxin, but you need to ingest massive amounts of this substance to affect the motor neurons. So the theory has really kind of fallen to the wayside. But it's every now and then, if another sports person is diagnosed, it's brought to the fore again. But it really hasn't been shown anywhere else in the world to be much of a risk factor as in Guam.
I presume the same would go with things like sports supplements and performance-enhancing drugs. There's some questions coming through on that, but again, little data, I presume.
So I had that as a fourth point in my slide about risk factors, but because there's absolutely no data on that, for understandable reasons, it's a very secretive thing to talk about. There's absolutely no data on that.
Great. Well, I mean, I'm not sure about everybody else, but I thoroughly enjoyed that 90 minutes. It's gone past very, very quickly. I think it's brought to the fore some nice discussion points, and certainly from Willie's presentation, we look forward to some excellent research going forward. From Franclo, we know there's a lot to learn in this, and hopefully the data accumulates and we get some answers to this. So thank you again to both of you. World-class presentations, I think really helped us understand this very complex topic much more, and we appreciate the effort, not only in giving up your time this evening, but in your preparation. So thank you very, very much for doing that, and hopefully we will meet again, either live at a conference with a glass of wine one day, or again on one of these webinars. So thank you very much for doing that. Thank you to everybody for attending. Thank you for the backup team's support, and thank you to the Lita and Asina group for everything you've done to support WiSH. Robin's going to put up a slide now with a link to a survey, and if you complete that survey, it will take you through to the website as well, and you'll also be able to be awarded your CPD points. So we'll leave this slide up for a while. It also advertises our next talk, which is on foot injuries in dancers and other athletes, and that will be next week. So we look forward to you joining us for that. So thank you very much for another very interesting talk and good attendance. We look forward to seeing you next week. Thank you.